Okay, well, hello everyone, and again, thank you for joining us today. This is the second of 5 sessions on the future of primary care in BC. I'm Veronique Siufi. I'm the racial equity researcher and policy analyst with BC Policy Solutions. In our organization, we're located on the unceded stolen territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. And for those that may not be familiar with our work, BC Policy Solutions is a progressive policy, public policy research institute. And we're looking for those redesigns in public policy that are going to make life in this province better, healthier, more sustainable, more affordable, and more just. So we've got economists calculating how we can better redistribute wealth and how investments in public and social infrastructure, are not only the right thing to do, but better for the balance sheets in the end. We've got social scientists like myself doing community-driven research. We're also a hub for cross-collaboration across community organizations, nonprofits, academics, and the labor movement. And then we also try and make all that work that we do behind the scenes accessible to all of you. So that's like what you're tuning in for today. So this series is going to teach you about a great example of how when we design public systems with equity in mind, meaning, when we make sure our systems work for the most marginalized, they actually end up working really great for everyone, and side benefit tend to be cost effective. But this requires, clear values-based guidelines, community responsiveness, stable funding, and that we stop treating our public services like market businesses. But I'm going to let Marcy take it from here. And if you don't know Marcy already, you're all very lucky to be joined by Marcy Cohen. Marcy has a long career in research, which has focused on public policy solutions to the current challenges in our healthcare system. She's worked for the Hospital Employees Union. She's worked as an adjunct faculty member in health sciences at Simon Fraser University and was a longtime board member and chair at the now closed Canadian Centre for Policy Alternatives BC office. But we're lucky to have her on our board at BC Policy Solutions. And if you sign up for our newsletter, you'll get to see her latest paper on how BC can and must do better with primary care, which is coming out soon. So I'll pass it on to Marcy now to get us started with our second session on the future of primary care in BC.
Thank you, Veronique. Wonderful to be here facilitating the session with our panelists from Ontario. Very much appreciate each of you taking time out of your busy schedules to be with us today, and so looking forward to the session. By way of background, this webinar has been designed to build on and deeper under our understanding of what was behind the idea introduced in our first session of the, quote, not-for-profit advantage. At that session, we had executive directors from 3 different team-based nonprofit primary care organizations in BC talk about the many advantages of nonprofit structures. So having that community mandate that makes it possible for them to play more of a leadership role in the local communities to better connect the different parts of the health system, to social care services, to remove bottlenecks to access, to support patients and providers, and how much people love working in an environment where they are supported by a team and empowered to make a positive difference in their community. But also they talked about their capacity as nonprofits to respond to unmet community needs and to do that so much more proactively than they can in many organizations. And that's because nonprofits have the capacity to fundraise and to apply for grants, to initiate innovative programs and new approaches to service delivery. And how proud they are of that. And yet at the same time, near the end of the webinar, there was a lot of deep distress coming from the panelists because many of these programs were about to be cut as part of BC government's austerity budget that was going to be released the next week, with no regard for the evidence that these initiatives were making a positive difference to people's health, reducing their reliance on emergency room care. The rationale for the cut simply that because these services were not funded permanently, were not part of the mainstream funding, they were funded year to year, often with year-end funding. For many, many years, they received funding. And because of this, they're the easiest to cut, and that was the only criteria. And it reminded me so much of that oft heard critique about the Canadian healthcare system as being a nation of pilot projects and not sustainable system change and improvement strategies. So all of that speaks really to the importance of this webinar and focusing on the Learning from Ontario success in creating a thriving not-for-profit primary care sector, which in no small measure is due to the Alliance for Healthier Communities, an outstanding not-for-profit organization that supports community-governed primary care organizations across Ontario and has done that by developing a sustained and evidence approach to health system transformation based on a commitment of all of their member organizations to focus their services on improving the health and well-being of people and communities facing barriers and reducing inequalities for those most at risk of ill health. So clearly a very strong equity focus, and doing this in a way that is collaborative, evidence-based, and designed to enhance the role and contribution of all primary care providers in Ontario, not just their own sector. And that is one of the things that I really appreciate. And they're doing that by trying to help these providers support those in greatest need, have the greatest risk of ill health. And, our BC context is quite different, but there's so much to be learned from the Alliance. And in terms of the organizational infrastructure they put in place, the potential for the BC Association of Community Health Centres to play a similar role with community health sector in British Columbia. So with that, I'm going to introduce the panelists. And the first person I want to introduce is Jen Quinlan. She is the CEO of the Flemingdon Community Health Centre, located in a densely multicultural community in northeastern Toronto. Jen has been recognized for her leadership role in developing a local hub in partnership with a local hospital and an umbrella community-based social service organization. And it is a fascinating model with so many different types of health and social support services in one place. And so you'll hear from Jen about that and many other things. Angie Kroeker, who is the ED of West Elgin Community Health Centre, serving 2 rural municipalities in Southwest Ontario. And Andy's recently done focused his advocacy and system change efforts on the development of a neighborhood hub locally, and in his role as the co-chair of the Alliance for Healthier Communities in rural and remote areas of the province. The last speaker is Jennifer Rayner, and Jennifer is the Research and Policy Director of the Alliance for Healthier Communities. The other 2 speakers are members of the Alliance. Jennifer has been in her role for 10 years, but she's been associated with the Alliance and previously the Association of Community Health Centres that goes back much further. Jennifer is also a research professor at the University of Western Ontario and an associate professor at the University of Toronto, working in the Faculty of Family Medicine at both these universities. Her work at the Alliance has contributed to the Alliance being recognized as one of the leading voices on health equity, interprofessional team-based primary care, and learning health systems, not only in Ontario, but across Canada and internationally. So with that, I'd like to introduce, go to the questions. And the first question is going to go to Jen and Andy. And it is to ask you guys to get us started, to give us a picture of what's happening on the ground. Can you tell us about some of the way your clinic has evolved over time, the people you serve, the values that underline the work that you do, and the team that makes all of that possible, just to get us going. Thank you. And so over to you, Jen.
Perfect. Thank you so much, Marcy, for the invitation, and to everyone attending. Really lovely to spend some time together. So as Marcy shared, my name is Jen Quinlan. I'm the CEO of Flemingdon Health Centre. I'm honored to hold that role for the last 6 years and to be in a neighborhood that really has strong roots in advocacy, and we're very lucky to work with our community partners. I'll tell you a little bit about our model and maybe some of the bright spots of things that we're proud of, as well as a bit of our evolution. So we are 51 years young. We just celebrated our 50th anniversary basically all year last year, and it was a really wonderful, reflective opportunity. Our model has been one really grounded in neighborhoods. So as Marcy said, we're in Northeast Toronto, very dense neighborhoods, a lot of high-rise communities, mostly newcomers and folks who are coming to Canada for the first time and calling our neighborhoods home. The neighborhoods that we primarily serve, if you're at all familiar with Toronto, are Flemingdon Park, Thorncliffe Park, and Peanut Plaza. All wonderful neighborhoods in Toronto that we have a long history in. We have sites in all three of those locations. So even though our model does not have the same access challenges as Andy's in rural Ontario, there are still access challenges in urban Ontario, and we do try and make sure that we're located as close to our communities as possible. With that, then the three sites are all sort of self-contained. They have a full team at each site. So physicians, nurse practitioners, nurses providing sort of comprehensive ongoing primary care. We've just added physician assistants recently, so that's a new role for us. And then we have a very diverse interprofessional team, which includes physiotherapists, dietitians, community health workers, chiropodists, and then we have a very strong prevention team as well, which includes health educators, health promoters, community development workers, and community health ambassadors. One of our sort of flagship or elements of our model that we're really proud of is hiring from within the community to empower community change. So the community health ambassador model, for example, is one we're really proud of. I know that's been something that has been a really key focus of us making sure that we're achieving some of our larger goals, which I'll talk about. We're also proud to be a teaching clinic. So we actually started out as a teaching clinic of a department in family and community medicine from the University of Toronto 51 years ago. And we remain the only community health center family medicine teaching clinic in Toronto. And it's a great opportunity for us to continue to work with learners. I think for anyone on the call, if you work with learners, it keeps you sharp, right? It keeps you engaged, but as well, it's an excellent recruitment process for us to keep family physicians engaged in our model. We're also really proud of our physician leadership. We have a medical director, Dr. Catherine Yu, who is responsible for doing a bunch of system planning from that physician lens. So she works across our neighborhoods with our funders, with our hospital partners to help make sure that communities get care as close to home as possible and that we're creating pathways in and out of the hospital system that benefit community. We're also really proud of our community-driven integrated care model. That's kind of the secret sauce of Flemingdon Health Center. And that really means that we're working to keep people as close to home as possible. We make sure that all of our services are available in multiple languages. We are the largest user of over-the-phone interpretation in Toronto from a community sector. So we provide a lot of interpretation for our medical services. And we partner in a way that creates an integrated system for our clients. So Marcy mentioned at the Thorncliffe Park Community Hub, one of the places we're really proud of, just 1 year old. It is a multi-service hub that is 67,000 square feet. It's actually what I'm working out of today. It was a former Target department store. So Ontario's loss of Target was a health hub gain. And really, I think the model is brought to life in this hub. So we have an integrated primary care organization, Health Access Thorncliffe Park, which is run by our community health center. But we also have a legal clinic in the hub. We have a midwifery program. We have an early years program. We have a community space. We have a community kitchen. And so the idea is really that this neighborhood health home and this community hub is an extension of people's home. People do come here without an appointment to socialize, to sit down. There's a lot of greenery. There's a lot of computers people can use to drop in. And that's really a low barrier way of folks to be able to come and access care. And while they're here, they may be approached by an ambassador or a volunteer who encourages them to join a group, maybe to take an exercise class. But also we make sure that people are aware what the benefits of primary care are. With the communities that we serve, a lot of folks are coming from other countries and other models of healthcare, or perhaps primary healthcare is not the foundation like it is in Ontario. And so we're really sometimes challenged to describe what the benefit of primary healthcare is to newcomers. And that's a big part of how the hub helps sort of articulate that and help bring people in and sort of explain how primary care can be the foundation and help them navigate to a number of different services. So we're really proud of the Thorncliffe Park Community Hub as one example of our community-driven integrated care. My last example I want to talk about is something that's a navigation clinic that we're really proud of. And it's one that we've just recently opened in an acute care space not far from our community. And it's a way in which we can catch people from the emergency department or being discharged from the hospital, provide some stabilization at that clinic, and then discharge them out into the community. Just in the first year of this model, we've supported over 3,800 unique clients, of which 1,600 of those were successfully attached to ongoing primary care. Of course, some others declined, even if we offered, and that's something we continue to work on. But we're really proud of the way in which our community-driven integrated model is sort of making those shifts in the health system and keeping people in community and highlighting the importance of longitudinal ongoing primary care. In terms of the last few years and the 51 years before that, I think that's kind of what I wanted to highlight now, recognizing that there's lots of opportunity for conversation and building on each other. And so I'm going to pass it to Andy. Thank you so much.
All right, thanks, Jen. So my name is Andy Kroeker. I'm the Executive Director of the West Elgin Community Health Center. So we're located halfway between London and Chatham in rural southwestern Ontario. We serve two small rural municipalities, so West Elgin and Dutton Dunwich, three small towns of West Lorne, Dutton, and Rodney. So just if there are any hockey fans out there, either for Team Canada or Canucks fans or former fans, Bo Horvat is from Rodney. He was one of our clients. His family's still a client. So even though he's not with the Canucks anymore, that may be a sour point. But so there's about 9,000 people here, 3,500 households, and about 600 square kilometers is the area that we cover. So we provide care to about 6,100 active clients. So really about 2/3 of the population. And of that, ongoing primary care is about 3,400, and programs and services is another 2,700. So we're not quite as old as Jen. We saw our first client in 1994. Sorry, I meant our building. Sorry, not you personally, Jen.
Ha ha ha. That's all right, Andy.
Because I'm much older than Jen personally. So. And then we opened our new building here in 2004. So being rural, our nearest emergency department is 22 kilometers away. And most of our referrals go to hospitals, and we have a series of hospitals that are all about 55 kilometers away. So transportation is a challenge and a very prominent social determinant of health for us and our clients. So our budget's just over $7.25 million. It's virtually all from the Provincial Ministry of Health. So we'd be considered to be a medium-sized CHC, so it's smaller than Jen. And most of our salaries and benefits accommodate about 85% of our operating costs. And that allows for about 55 full-time staff and 100 volunteers. So it's the 100 volunteers that really make the difference for us. So they always say if you've seen one CHC, you've seen one CHC. In our case, we have, similar to Jen, we have our community health people, so our primary care and professional team. And then we have community support services for seniors and assisted living program. And so Marcy suggested I give you a bit of an example of wraparound care for one of our clients. So this isn't necessarily a typical client, but this is an example of one of our clients. So they're a primary care client. So they get physiotherapy through us. They've had a chronic disease nurse practitioner who gave them pain therapy and exercise programs. They use our volunteer drivers to get transportation to appointments in the nearby cities and hospitals. They use our mental health therapist because they have mental health challenges. And the mental health therapist actually arranged for us to use our client funds to buy him a 3-wheel bike so he can travel around our little town here because he doesn't have a car. He's also served by our assisted living personal support workers who support him with his medication management and wellness checks. And unfortunately, he also has diabetes, so our nurse and dietitian provide care. And not surprisingly, because he has diabetes, he has challenges with feet, so our foot care nurse also provides care for him. And if that's not enough, we have a system navigator who provides assistance with a lot of things, but one of the examples he used was when he had his cell phone cut off. He came to our system navigator and asked for her help to get his cell phone reestablished. On top of that, he comes to our food pantry once a week, and he's also participated in our smoking cessation programs to varying degrees of success. So that's one person in terms of wraparound and what the potential is. And Jen would have similar examples that you could offer. And we do offer a lot of other programs as well. So I guess our philosophy really is if we don't do it, we bring in others who will. In addition to our staff, we partner with other organizations, Canadian Mental Health Association, Addiction Services. Gamma Dynacare has a lab day here 1 day a week. A child psychiatrist comes in on a frequent basis. And we have physiotherapy services that we also purchase from next door. We also offer supply, we supply harm reduction supplies in partnership with public health. We partner with the Alzheimer's Society, with the Victorian Order of Nurses and others, and offer space for them to offer their programs here. So we really consider ourselves to be a rural health hub with all of these services under one roof. And in rural, often we're the only game in town, and so we do it because no one else will. And that was especially true during COVID, when we were the only service that stayed open while everyone else shut down. So we have an amazing group. Our values, compassion, excellence, collaboration, accountability, respect, and equity. And I think our staff and our volunteers and our board live that all the time.
Thank you. Thank you. So I'm now going to turn it over to Jennifer. And Jennifer, I wonder if you could give us some of the history behind the Alliance, how it developed out of the Community Health Center Association, the kind of systems change work you're doing in the Alliance more recently. So over to you to give us more of the provincial perspective.
Thanks, Marcy. So as Marcy said, I'm coming to you from a place called the Alliance for Healthcare Communities, and we're a member association. And we first opened our doors as the Association of Ontario Health Centres way back in 1982. We had 6 members. So since then, we've continued to grow, and as new CHCs were funded by the mid-90s, there were 54 community health centres in Ontario. And we continued to grow. And at that time, we also brought in Aboriginal Health Access Centres, which we refer to as AHACs. So Ontario is a bit of an alphabet soup with primary care. So we've got community health centres, and we've got Indigenous primary health care organizations, or AHACs, under our umbrella. I wanted to talk about a few milestones that really helped pave our way to where we are as an association right now, but also helped, I think, pave the way for community health centres. So way back in 1999, this is when I first started in the community health center world. We were tasked with figuring out whether CHCs could be identified as a program or evaluated as a program. So at that point in time, there was like I said, 54 community health centers. Everybody thought they were incredibly unique in doing their own thing. Like Andy said, if you've seen one CHC, you've seen one CHC. So at the time, the ministry, the association, and the community health centers thought, could we even be considered a program in which to be evaluated? And of course we could. Everyone had the same underlying objectives and values, and similar roadmap to service delivery. Now, this was really an important pivotal moment for us because as a salary-based model, all of our employees that work in community health centers are salary, including physicians. It meant we were invisible. So this gave us a way to start talking about our sector in sort of really tangible ways and measure the work we were doing. In 2009, and you'll get the drift of why I'm telling you things because they were sort of these key milestones. In 2009, we made a decision with all of the organizations that were part of the Alliance to shift to operate as a cohesive sector and have one voice for community governed primary care. You can imagine this was a pretty powerful decision because then we became one loud voice that talked about health equity, comprehensive primary health care, team-based care, community governance, and it really enabled us to work as a sector and make decisions as a sector. And a couple of big things we did is that we adopted a set of evaluation and data elements that really described who we were and what we did. It ensured decisions reflected the consensus of members. It enabled us to adopt one EMR, which was a monumental decision that enabled us to put those data standards into our electronic medical record, have everybody collect the same data so we could tell the same story. We now, fast forward, we can link that data to administrative databases. We've built a data warehouse. We've got strong performance measurement. And like Marcy said, we've sort of really adopted this learning health system approach. This EMR was a pivotal moment for us because before this, the ministry kind of owned our data. So we had reporting standards, and somewhere in the ministry there's like boxes and boxes of paper, or lots and lots of data that had this CHC information, but it wasn't looked at or used. For example, I was seconded to the ministry and I never once looked at data, and I'm a data person. So by endorsing this strategy, we really put data back into the hands of providers and leaders that needed to use this information for reporting, accountability, and planning. The other really important decision that we made around this sort of shared consensus and shared decision making was a committee structure. And this committee structure at the Alliance and within our provincial members really helps to guide all of our work. It includes three main groups. One is a strategy group that really helps sort of think about the strategy, long-term goals, where we're at, sort of really strategic thinking on what we need to do to move ourselves forward. There's a performance management group that we now call EPIC, Equity, Performance, Improvement, and Change. And this includes all of our measurement standards, indicators, research, learning, and improvement, and an information management group, which is sort of the nuts and bolts of our IMS system, including the EMR and data warehouse. So these committees are supported by the Alliance, but really the members are what make them. Like they're the chair, they're the trusted leaders within the sector that do the work. We're the worker bees at the Alliance, and the members are really leading this work. We also have several equity focused groups that are led by member centers, including a Francophone group, a 2S LGBTQ plus group, a Black Health, and a rural remote northern group like Andy mentioned, who's the co-chair. Now in 2013, we adopted a model of health and well-being, and this focused on holistic anti-oppressive care. It's been mapped to the evaluation framework, but it's a very comprehensive roadmap to service delivery that every single member has adopted and embraced. So this again was a pretty powerful move because we've got now 120 organizations that have adopted the same model of health and well-being that includes health equity, anti-oppressive care, team-based care, a focus on population health, a focus on ensuring we're accountable and efficient, as well as other foundational elements such as health promotion, community development, and of course being community governed. So at this point in 2013, the Association of Ontario Health Centres had a bunch of other primary care models that were interested in kind of joining this movement. That included nurse practitioner-led clinics, various family health organizations, and various family health teams that really felt they wanted to embrace this model of health and well-being, use these shared data standards, have a strong voice in health equity. So they wanted to join. So we really need to sort of think about our name. And that's when we shifted to become the Alliance for Healthier Communities to really reflect this broader membership. Now, I chose these actions and milestones to really highlight the path because I think they situated us perfectly to be a solution for the Ministry of Health and our regional health kind of operational arm, which we refer to as Ontario Health. So we'd figured out how to measure team-based primary health care. No one else had it in Ontario. We'd figured out how to link this data to administrative data sets, monitor our progress and be accountable to our funder, and ensure a high degree of community engagement. And the Ministry of Health and Ontario Health both see Alliance and the members as problem solvers. Sometimes this is a good thing, and other times it's hard because we're always having to roll up our sleeves and do extra work and kind of figure out how to make sure that the people sometimes most at risk don't get left behind. And we often get called to take a leadership role in implementation and innovation. And there's a couple of examples that I just wanted to share quickly. One was this project called Team Care, and it really was built off some work that was being done in Toronto called SPIN, Solo Practitioners in Need. So in Ontario, like other provinces, there was a bunch of solo primary care providers that were looking at community health centers saying, boy, if I only had access to team-based care, I could do my patients better. And so what we did is we collaborated with those solo primary care providers to help ensure that the patients that needed team-based care got this QI team-based care. And this was rolled out across the province in many, many sites. This, of course, got this got the attention of the ministry and later Ontario Health. And it really set the stage for sort of our more recent expansion, which is these neighborhood health hubs, which we'll talk about later. But it's really how do we have a broader lens than just the folks entering our clinic doors and help serve a community. And we do this with quality improvement data, but also community governance. I think when you're community governed, you have to think beyond the folks you serve and look at the communities for which you're situated. And I think that's what's made our model so powerful. And the Ministry of and Ontario Health keep recognizing that we're sort of a solution-based organization. And sometimes hard, but our doors get knocked a lot to do this work. And I feel like Jen and Andy, exemplify this. So I'm really happy that these two folks are on the call so you can hear about their work and in real time.
Thank you. Thank you, Jennifer. Okay, the next question is for Andy and Jen. And this time we'll start with Jen and then go to Andy. And the question is really asking you to, I did that wrong. Sorry, it's Andy first and then Jen. So the question is, can you talk about the internal and external supports that have helped you do all of this? So your relationship to the Alliance and your own community, and just to fill out some of the things that Jennifer's talked on the provincial level in terms of what it means when you have that support on the ground.
All right, thanks. Yeah, so I think Jennifer talked about community governance, and that certainly is one of the internal supports that I have. So we do have a board of community directors, so people from the community who have the best interests of the organization and the clients and the community at heart. Certainly, it's varied over time in terms of the size, but right now we have between 7 and 9 directors on our board. And I just did a survey before Christmas, and I found we've actually had 64 directors in the time that I've been here. So there's a lot of people willing to step up and help it and to get the work done that needs to be done. So the board also takes on a responsibility for advocacy, which is something that they've been doing a lot lately. One of the areas that we've struggled a bit with being rural is the challenges with staff compensation and getting people for what we pay them compared to the hospitals, and adding a commute and all those extra time and dollar expenses on top of that. So they actually collected 800 community member signatures at 2 fall fairs. And then this was presented in the Ontario legislature as a way of trying to draw attention to the province and the government about the need for better funding. So that was certainly one of the highlights of the board. They've also partnered with the local municipal councils because, as I'm sure you're aware, in rural Ontario and rural Canada, there are challenges with healthcare, and its impacts spill over into municipal areas. And we've actually have had previous council members on our representation on our board. We also try to find other ways to get the community voice into our organization and into our decision making. We did have 2 community town halls in the fall, so we're trying to start that up. They were sparsely attended, but we're going to be trying that again in the spring and the fall again. We've struck a client and family advisory council. So again, trying to give people in the community the opportunity to come to us with what they're hearing on the street or in the grocery store or at the Tim Hortons in terms of issues that they're hearing that people don't necessarily come to us about. And even this week, so we had a meeting yesterday and we vetted our quality improvement plan through them and said, okay, are there other things that we need to be doing as an organization to improve the quality of care for you as clients or for the community? I made reference earlier to our 100 volunteers. It's amazing. I mean, the amount of work that they do to deliver our programs and support our clients has been unbelievable. And we certainly couldn't do half of what we do without having them. So that's most of the internal. If we move externally, I think Jen certainly has started talking about the evolution of the Ontario health teams. That really started in our area about 7 years ago in terms of trying to get a coordinated joint planning and relationship building across all the sectors, including primary care. And myself and a colleague were two of the initiators with our local hospital CEO. And again, that came out of work that the Alliance was encouraging us to participate in that and to get involved in that from the get-go. So we did that as well. So this has led up to just in the past year, we have developed a neighborhood health home model for Elgin County, just as others are doing that across Ontario. It is based on Dr. Jane Philpott's school board model, where everyone should get access to primary care physician or nurse practitioner. So right now it's a plan, and right now we have a hub and spoke model where there would be a hub in St. Thomas, and we would essentially be the spoke for West Elgin. And so we're trying to figure out what that would mean. And obviously we would need more resources and more funding, because you can't just take on the 10,000 people in Elgin who don't have care right now, or the other 20,000 people in Elgin who travel outside of Elgin to get care. So it's an interesting starting point, but we are starting to work better together. We did work on a couple of processes across Elgin to show that we are working together and trying to bust some of these silos that have traditionally existed in healthcare. We are fortunate in Elgin is that we do have 2 community health centers and 2 family health teams that have worked well together. So we have 4 strong teams and 4 strong organizations. And we've had joint board and senior leaders planning meetings as well. So again, realizing that we can't do this alone and trying to figure out how we work with our primary care partners to advance primary care. In our county, so we've had a primary care alliance that's now morphing into a primary care network. And so that group is just starting to hit the ground running. So it's really about trying to get all the solo physicians or the people who are practicing in isolation, getting into more of a unified voice across all of Elgin County. In terms, so we've gone from inside to Elgin, and then obviously at the provincial level, the Alliance, Jennifer is just amazing. You can't have her, you can't steal her. I'm sorry. But she is amazing. And they provide a great centralized expertise. Jennifer obviously is a quality and research guru. She said they provide support for our electronic medical record. They have privacy expertise. They have communities of practice for finance and HR. Often you feel you're an N of one as an organization or as an ED, and certainly they do a great job in bringing groups together to get us to feel that we are part of a bigger solution. As mentioned, so a few years ago, the Alliance did, through some encouraging, identify rural, remote, and northern as one of the priority populations. As I said, I've been here for 16 years, and probably for the first 10 years, some of these subcommittees didn't feel that they applied as much in rural Ontario. We are still very conservative. We are still very white English speaking. And so some of the priority populations that have been identified were not the messaging wasn't necessarily received well as here. So we know rural, remote, and northern have poor health outcomes, more challenges with getting access to transportation, access to services, lab services, diagnostic services. And so I've been fortunate to be able to co-chair that with a colleague out of Thunder Bay, and we've been advocating on moving these rural, remote, and northern issues forward. We've had 2 symposia so far, and we're planning a 3rd one to get people together to have speak in a larger voice. And one of the real positive things is that the Alliance is starting to develop strategic partners with rural and urban municipal associations across the province, right? So the Rural Ontario Municipality Association, the Association of Municipalities of Ontario, because municipalities are dealing with the same issues we are every day, right? So health, they get calls about healthcare resource shortages. They can't, the emergency department is closing. I can't get a physician. I can't get a nurse practitioner. This person's unhoused. This person has mental health and addictions concerns. So they are dealing with the same issues that we have. So that's a natural partnership that we are starting to build across with the benefit of the Alliance. The other one that we do have is based on our assisted living community support services programs. There's also the Ontario Community Support Association, which is a similar model to the Alliance. And through their advocacy efforts, they've been able to get us increases in funding, say, for our personal support workers to get their wage increases to narrow the gap with long-term care in hospitals. So I think those are some of the internal, local, and then provincial benefits that have made my job a lot easier.
Thanks, Andy. I'll build a little bit on that. And, as you can see, there's an urban and a rural example, but some of the enablers are similar. And even though Andy and I don't see each other too much, we do get to connect twice a year as well and have a larger opportunity cross-provincially. So it does feel like, as Andy said, you're never alone and you can really reach out, and the Alliance does a great job of that. For Flemingdon Health Centre, our internal supports really obviously start with our strong frontline teams. I did see a question in the chat about the community health ambassador model, so maybe I'll just spend a little bit of time talking about how we really knit through our teams health and social care. Because we do have communities that we serve that have lots of barriers, whether that be language or perhaps status, maybe income, race. So we really have to make sure that our services are really community informed so that we can make sure that people access and find them meaningful, as well as improve their health outcomes. So during the pandemic, we were one of the lowest vaccination rates in Toronto as a neighborhood. So we had really high rates of COVID transmission and really low rates of vaccination. And when we got together as community reps, agencies, hospital, really what it came down to was that many of our community members were essential workers. They were out doing important work, and they were not able to, be on Vax Hunters or be on social media and line up for a very long period of time to get a vaccine. And so we really went with a hyper-local approach for our vaccination program. And I would say that was a big shift for our organization. And for our health system and our health system partners, and one we've not turned back from since. So we would do, for example, hotspotting. We would look at which buildings in our communities have the highest rates of transmission. And then we would go in and we would hire people who lived in those buildings, who spoke those languages, who were maybe natural organizers, maybe someone who did a lot of, work with the school or with children. We would hire them. They would become paid staff, employees of Flemingdon Health Centre, and their role and their responsibility was to make sure that their building had all the health information they needed and was connected to us as the health center. And so during the pandemic, of course, that meant that a nurse would come and vaccinate people right in their hallways. And beyond that, we since the moving into recovery during the pandemic, we had things like our cancer screening catch-up. So our ambassadors were instrumental in that. We targeted particular communities that were underscreened and had become further underscreened during the pandemic to increase cancer screening. So our community health ambassador model and the ways in which we're trying to connect to community and make it easy and reduce barriers is a big part of our interprofessional primary care team and a big part of our model. I think our physicians also benefit from having care navigators. Andy mentioned an example of a care navigator before, but I think that's a really critical role. When we look at some of our more complex clients, a lot of times, we see maybe one client coming and making appointments with our team, maybe as much as, 50 or 80 times in a year. And that can be a significant drain on our staff, but also probably not the best impact on the client, right? Getting a series of disconnected appointments, and perhaps they're not getting their needs met. And so we pulled a list of clients that had a profile like that, and we assigned each of them a health system navigator. And those people proactively reach out to those clients. So they check in on them weekly, whether that be through a phone call, through a scheduled visit, or an unscheduled visit. And we've found it reduced significantly the burden on the physicians and nurse practitioners and nurses, because a lot of times what these clients needed was the social care aspect, right? They needed help with forms. Maybe they needed help with, some complex navigation. Maybe they missed a specialist appointment and now they're trying to get another referral. And frankly, to wait for an appointment with a physician to act that is not an effective use of both the client's time and the provider's time. So I think our internal processes are some of the things we're really, really proud of, both by being closely connected to community through ambassadors, but also maximizing the scope and the care of our clinical teams through some of these additional roles. Andy mentioned also some of the internal things involve, if we don't do it ourselves, we find someone to partner with. And so I think physically in our space, there's tons of different service providers. One example that I thought would be helpful to share in this context is 2 of our 3 sites are connected with dental clinics. And we know that that's a really important enabler of dental care being something that's not typically accessible, right? Often there's financial barriers, and we partner with our public health to offer an integrated dental care program, which helps our clients. And so that's something where I'd say, obviously we are not funded for dental, but we make sure to create space, advocate with the ministry to build operatories and different things so that we can house dental and make sure that it's close to home for our clients. So those are some of the internal examples, both staff and partners, that I think make our model of community-driven integrated care successful. If I shift up to the board and the leadership, so we are lucky to have a wonderful leadership and board team. Our board, much like Andy's, are community volunteers. We have between 11 and 14 board members at any given time. But one special element in our bylaws as a nonprofit corporation is that 4 of our board seats have to be held by clients of the health center. And so that is really living our values. That's really making sure that it's not lip service or tokenism, but that in fact 4 of my bosses are clients of the health center. Some people can find that a bit challenging to navigate in terms of the different hats that people wear. But frankly, I think there's more synergy than conflict there, and I appreciate that they bring a very unique and specific lens, and I think they really ground the rest of the board to make sure that the lens of our decision making is in terms of what benefits the community. We have had a recent shift in our governance model and some of our governance questions. And what I would say is we're moving a little bit more away from what does this do for the organization to what does this strengthen at the system level. And that's been a key shift for us at our board. It means we make different decisions. Sometimes it means we make riskier decisions, or perhaps we, try out new things. And it's really allowed the board to kind of give the organizational leadership permission to be a bit more at the cutting edge, right? To be a bit more sort of focused on innovation, to be able to try new partnerships, try new models like the navigation clinic that I discussed earlier. And I found that to be a really helpful framework to shift from does this benefit our organization to does this benefit our system and the community? And that's been an important shift for our board and our leadership. Externally, we're very lucky to work in a community that has lots of partners to work with. And we have a very close relationship with our Ontario Health funders. I think, there's no secret that you need your funders to want to partner with you. So I spend a significant amount of my time on kind of small p politics with Ontario Health and the Ministry of Health, as well as big P politics with elected officials. I know Andy talked a lot about municipal connections. That's important for us as well as provincial connections, which of course is our primary funder. I think, when we're doing some of this work in partnership, it's about kind of taking a step back, maybe not leading with what's most important for you as a leader. And I find working in collaboration and with these kind of integrated models, one where you kind of have to be egoless, you have to really listen, you have to really check your assumptions. And so I would say as a leader myself, I've also had to change some of my skills over the last few years to work in Ontario Health teams, to work in integrated care, and to work in the messiness that brings. There's a lot less certainty and there's a lot more trial and error and learning. And one of the areas that we lean heavily on the Alliance for is the learning health system approach. That's an area that I think Ontario has embraced, and I'm sure BC is also I'm looking at that kind of ecosystem of learning model. And so it's one that I find very helpful when we're talking about planning either at a neighborhood or at a county, that we bring in sort of different pieces and try and see how maybe there could be levers of change that have multiplying or amplifying effects. And so, yeah, I would say we lean on the Alliance and some of our smart colleagues there, like I don't know if we said Dr. Jennifer Rayner, but we should say Dr. Jennifer Rayner and her research team. And frankly, the research that the Alliance does is the one that I use the most. So definitely in terms of some of the research around cost, there's been some excellent work demonstrating investment in primary care, investment in equity models of the neighborhood health home, and how it saves money in the overall health system. We are able to now quote things like we see clients that are 60% more complex than the average Ontarian, but use the emergency department for matters that are best served elsewhere less than 30% of the time. So like we really have this very different kind of way of speaking. I know, for example, for the cost of a single trip to the emergency department in Toronto, Flemingdon Health Centre could care for the same person for the entire year. So these types of pieces of information, way of bringing together policy research and action, I think really help us on the ground. And I'm very grateful to the Alliance for some of that work. I also think, to Andy's point, in Ontario right now, we are very lucky to be having a real moment shining on primary care with Dr. Jane Philpott, but also with a new piece of legislation that enacts sort of like what it looks like for a high functioning primary care system, and will hold us accountable to that. And I think Jen Rayner can speak much better to that than I can, but I do think there is like a moment in Ontario right now, at least till 2029, when presumably 100% of Ontarians will be attached. And then what is a bit of a question, but I would say it's a great time to be in primary care in Ontario right now, a great time to innovate, and the internal and the external environment is lining up for once. So that's a pretty special time.
Thank you, Jen. Thank you both, Andy and Jen. So much stuff. So good. Really wonderful to hear. Jennifer, so can you actually talk a bit more about this big initiative and what's happening right now in terms of the attachment initiative, where it comes from, where it's going, and what you've done in the Alliance?
Yeah, for sure.
Has
Thanks.
made such a big difference.
Thanks. It's a super exciting time, but also a bit of a daunting time. So, like other provinces across Canada, Ontario has a significant number of people who do not have a primary care provider. So, about a year ago, Jane Philpott was asked to chair a group called the Primary Care Action Team. And like Jen and Andy have said, their goal is 100% attachment in 4 years. And along with this, they're providing funding like never seen before for primary healthcare. So it was sort of interesting. I don't know, probably about 8 months ago, the Alliance was asked to provide a vision for what we see as the future for primary healthcare. And so we wrote something pretty quick, just, talking about a neighborhood health home. We were strategic and aligned it to the six objectives that were outlined in the new Primary Care Act, but we used stronger language. So they talked about province-wide access. This fit perfectly within the neighborhood health home where we had team-based care organizations acting as the hub that supported like sort of this geographical area and supported all the other primary care in the region. We talked about connected care, that services were coordinated with existing health and community and social services, that it was convenient, that was timely, that provided good access. We use strong words like health equity. They used words like inclusive, but it was really about services that were delivered that are free from barriers and discrimination. Empowerment that allowed patients to access their personal health information, and that we created a system that was responsive. So we created this vision paper. It's been provided to you in the chat, and it's short. It was short and easy. And since then, we've prepared a toolkit that really digs deep. And I'll put a link in the chat for you. It really digs deep into sort of case examples and all sorts of tips and tools that you can use to actually increase attachment. And we're providing it to everybody. So that's sort of an interesting shift that we've made. So we really felt in order to change the landscape of primary healthcare, we needed to speak beyond just our 120 members. And it was interesting, when we built the vision paper, when I wrote it, it was really highlighting work like Jen and Andy's place. So, when we did a webinar talking about the vision, all of our members were like, "Yeah, okay, so what? What are you talking about that's new?" But for other primary care models, this was really revolutionary. How do we support a whole neighborhood? How do we do population health? How do we address health equity? And so for us, the Alliance members, this is bread in our bones. For everybody else, this was quite new. So this toolkit we've been spreading and scaling across the province as well, regardless if you're an Alliance member or not. So happy to share it with you all as well. So one of the key pillars that we're putting forward in the neighborhood health home is that places are community governed, and this really emphasizes that the community members themselves will help have a major role, like Jen described and Andy described, in planning and monitoring and making sure the services are appropriate. So one of the really interesting pieces with this new primary care initiative, that's huge, $2.1 billion over the next 4 years to support team-based primary care, is that the funding is only going to team-based care models. So it's not going directly to solo physicians or group physicians. It's only going to groups that do team-based care already. So this includes physicians and nurse practitioners, but they have to be in a team model, or they could be creating a new community health center, nurse practitioner-led clinic, or family health team. So they can create a net new one, but they're just supporting these team-based models. So that's sort of a key thing. And the other really interesting way they're implementing this is that only one expression of interest, they're doing this through expressions of interest. Each team must put an expression of interest in, is being accepted per Ontario Health Team. So that's a geographical catchment area that includes an attributable population. So what's good about this is that it's forcing conversations to happen. It's forcing collaborations to happen that might not have occurred if multiple expressions of interest were being accepted. So it's really forcing a way of working that they're hoping that will continue in the future. And another thing we did at the Alliance was, we created a template for people to complete their EOI. So we were like, if you're putting forward a neighborhood health home and you're filling out the expression of interest, here is what you want to say in all these different, questions. And I think that was pretty helpful for people. We also provided data and a whole bunch of other information for people to kind of fill these expressions of interest out properly. And so, what we're finding through implementation that you'll see in some of the case examples is that for teams that are hiring link workers, community ambassadors, like Jen talked about, social workers, it's really freeing up time for the physicians and nurse practitioners to see more people. So I don't at all want to diminish the work that physicians and nurse practitioners are carrying right now, but we always have said that this attachment and 100% attachment can't be solely on the backs of physicians and nurse practitioners. And what we're finding is if you have the right person provide the care, you're really freeing up time. So, for example, we've done some work and we're seeing that about 40% of visits to physicians could be better managed by a social worker or a community health worker to help people get navigated to the right services. So we're freeing up time for people to see new patients. We've seen the direct benefit, I think, of this being embedded with team-based care organizations because they've also got strong leadership. And so you've got folks like Jen and Andy that are able to build the relationships with other providers and kind of make sure those strategic relationships and collaborations are being done that best meet the needs of the community. And I think OH in the ministry, Ontario Health and the ministry saw this, and that's sort of the reason why they're thinking, let's include the money going to team-based care organizations. They're supported by community boards, the voice of communities. They're led by leaders that can bring people together to build collaborations, and it ensures the organizations are laser focused on the needs of the community, not just the folks who are already walking through the clinic door. And this is really important if you're trying to be increase capacity and be innovative. If you're restricted by, your bottom line or you're focused on the patient that you've got on your roster already, it's hard for you to really see beyond that, I think, and, focus on the community. So I feel like they've set this up to be positive. Now we're going to talk later about some worries, and I'll talk about that later. But I feel like we've been given an opportunity like we've never been given before in Ontario.
Now,
Thank
no,
you.
normally we jump in here and we do some Q&A. I don't have a ton of questions in the Q&A. So while we give some time for folks to pop their questions into the Q&A, Marcy, why don't I let you ask our panelists one more round of questions?
Okay, great. And I just wanted to say one thing, which is when they talk about team-based care in Ontario, all of those are already nonprofits, not so true in BC. But that's kind of the link to the not-for-profit advantage that between the two provinces. So the last question is this question about moving forward, what you see both as the promise and the vulnerability. And if you can be a bit shorter in this part of the conversation, that would be great. But still really good to think about, because we've really focused on the positive, and good to do that more, but also important to understand we are living through difficult times, and I'm sure that is also impacting you guys. So for this question, we'll start with Andy. We'll start with Jen, sorry, Andy, and then Jennifer.
Great. Yeah, so in terms of promising and not so promising, for me, I think the promising is this alignment of what our communities need, which is attachment to team-based care with what is being funded. So a rare time and one where we're doing our best to maximize. But what I also think is important is that we use this time to build coalitions, to build networks, to build integrated systems, rather than just everyone growing on their own. Because frankly, this growth will stop, and then we'll be left with making sure that what we have can last and can have an impact in a more longitudinal way. And so, using the opportunity to create local primary care networks where patients can be moved if needed. Maybe one team has a really good home visiting program, and as patients age in another team, they automatically get transferred. Like ways in which we're working together so that people do not experience either a discharge or a loss of team-based primary care. So I think that's really important. As a leader, for me, I'm really working on the skills and the opportunities to build my relationships. And so, for that, I'm learning and trying to learn new models. I do really like reading Frey and Morris. If anyone likes reading sort of like social change, I bet you the BC Policy Group does, as well as getting to Maybe. So I'd say some of that leadership and reading is really about like, when you are building trust, what does it look like? Trust is a word we throw around a lot in healthcare, and I think clients and patients and communities often trust their individual provider, but I don't think they trust the system. And so that's a thing that is really important to us as we're growing. And Frey and Morris break down trust to be where logic, authenticity, and empathy come together. And I just really like that. I think that really speaks to how we should be building our integrated models, how we should be leading, as well as how we can make these connections across organizations and across systems. Where I'd be worried or want to pay special attention and maybe think about new ways of doing things would be, the eroding social safety net, the fact that our clients are more complex, have less resources, are, struggling to make ends meet. I think, across Canada right now, of course, food prices and being able to eat healthy food is a real struggle. We also know that we have kids that need to contribute to the family income, so needing to, maybe compromise their school attendance in order to support family or maybe help care for younger kids when parents need to work extra shifts. So I think, when we're trying to get people to prioritize primary care and prevention, at the same time as their lives are so much more complex and their health need or their needs are so much more acute, it's hard to prioritize, getting a mammogram or taking care of your diabetes. And so the more we can work to lessen the barriers, being open in the evenings, being open weekends, making sure we're physically open as well as virtually open, making sure people can maybe book their own appointments, like all these pieces that help to lessen the challenge with which people can access us. I mean, you shouldn't be able to, book a private service easier than finding your family doctor, right? So some of these innovations and some of these ways in which we've kind of maybe kept some of the barriers, not because we want them, but because we haven't invested in the ways of maybe creating more technology or more opportunities for clients to have better access to us. That would be where I would have some concerns. And I think the only way for us to be able to make any dent on that would be, again, as networked, integrated systems. Looking at, Jen talked about all of us being on the same EMR, but maybe all of us have the same digitally connected front desk, right? And that helps move patients more seamlessly. So I think there's different ways that we're investing and perhaps that our resources are sunk that keep us from innovating. And so those would be some changes I would hope that Flemingdon Health Center can embrace. Thank you so much.
Okay, so certainly, as Jennifer said, $2.1 billion is a great start, but everybody knows that's not going to be enough to do what needs to get done to attach everybody. Certainly, there are concerns about the focus on attachment and not access. You can be attached to someone but not be able to get an appointment for months, right? So I think that is something we're wrestling with, along with the fact that our funders aren't considering client complexity when they're giving the money out. They're saying you're going to see this many people to get this amount of money. So I think that's a bit of a challenge. I think the other reality is they're shoveling all this money out the door, but they haven't been shoveling money out for our current staff who have been underpaid for years. So operating dollars, it's great. We have amazing staff, who have gone years without salary increases. Operating dollars have not increased. I think our operating budget's gone up 4.5% in the 15 years that I've been here. So it's kind of hard when your IT and all these other costs keep going up. I think we're still struggling with health human resource shortages everywhere. And in our case, we had 2 therapists leave 2 years ago to work at hospitals. They get 30% more pay, no commute, and the team's only now getting stabilized. And we had to go through 4 hires to get to to where we're at now, and that builds up a 10-month wait list for mental health services in our areas. So that is a challenge for sure. And I think the biggest one, if not the biggest one, is our nurse practitioner salaries. I mean, we are just telling nurse practitioners to take on the same workload as physicians and the same client complexity, and our nurse practitioners are getting 40% of what our physicians are making. And so how can we expect them to do that and to take on 2 million people in Ontario without providers until they get some kind of reasonable compensation for the work that they do? So I think recruitment and retention is going to be a challenge. Certainly one of the positives, at least from my team's perspective, is the use of AI for charting. I've been in healthcare for too many years where we've heard, of all these technical solutions that are going to happen, and yet we're still faxing records back and forth and we can't talk back and forth. But they've just jumped on the scribe bandwagon over the past year and a bit, and this was their idea, and their uptake has been great. So I'm not sure of other potential uses for AI. Take them with a grain of salt. But there might be other potential solutions. But again, I've been hearing from IT vendors for 20, 30 years about the solutions they have, and I'm still waiting. But AI, at least for scribes, seems to work. So we'll pass it over to Jennifer then.
Thanks. Now I'll be quick because you sort of touched on one of the things. I think the biggest vulnerability as a system right at this moment is related to the push for attachment without a focus on health equity or, like Andy mentioned, considerations of access. And we've learned over and over again by focusing on numbers alone, the people with the most barriers or vulnerabilities will be left behind. So super worried about that. We keep talking about this three-legged stool at the Alliance. And of course, attachment is appointment is important, but everyone needs to have a primary care clinician, but that should be your lowest common denominator, and access to team-based care. But if you don't focus on health equity, you'll leave people behind, and those are often the folks that need the most support. And of course, the other leg is access. You can attach everybody, but if they don't have access to care, it's like, what have you actually done? I think the thing that gives me the most, like, that I'm sort of really excited about, and Jen mentioned this, is we've just established a Primary Care Act. So for people that with policy hats, like, this is huge for us. It places primary care as a foundation of Ontario's healthcare system. It sets out 6 clear objectives that have oomph, and it sets some criteria for what people can expect for primary care. And I feel like primary care has never been in the spotlight like this before. So we've had this massive opportunity, and we know that people that have a strong primary care foundation around the world have better health outcomes, have better integrated care, like all the good stuff. So I feel like if we can actually get through the next 4 years, we've set the stage for a pretty strong foundation.
Thank you to all our panelists. Now I've got some questions piling up in here. So let me start getting to them. I've got one question, and Andy, you touched on this a little bit. I've got one question about, nurse practitioner versus family physician and what the health outcomes are like. And, you mentioned that they do a lot of the same work, and now this doesn't have to be you answering, Andy, anybody can answer this question, but, can one of you talk a little bit about the value of nurse practitioners in these roles? And I will flag for the audience that we do have a session coming up. The 4th session on April 8th will all be really focused on the role of nurse practitioners and nurses. But those two roles are not the same. So yeah, maybe one of you can speak to this a little bit.
Well, I can start, and Jennifer can fill in, but certainly, and it varies, right? Because nurse practitioners are used differently, even in different CHCs. So in our case, our nurse practitioners are our most responsible provider. right? So there might be the odd occasion where they need to consult with the physicians in terms of a second opinion. One of the challenges they have faced in the past, quite frankly, is when they make referrals outside of the organization, it's the external organizations that require a physician signature or physician sign off. So that further complicates that. But so it really depends on how you're using your nurse practitioners, whether they're working to their full scope of practice or not. In our case, our nurse practitioners are working to their full scope of practice. They are the most responsible provider. They are not just a right-hand person for the physician. So I think that that's one of the distinctions, and I think that's one of the conversations that the Alliance is trying to start to have is can we at least acknowledge those nurse practitioners who are most responsible provider and giving them some recognition and hopefully pay to allow for that.
Yeah, and I'll just mention that almost all of the nurse practitioners within the Alliance work as most responsible provider. They carry their own panels. And I did my postdoc working on nurse practitioners. I followed them around the province, and the outcomes are similar. Their complexities are similar. The numbers of clients they see are similar. I think sometimes there's different expectations, but in reality, they're seeing similar numbers of people. And the client experience is through the roof. So people love the care they're getting from nurse practitioners.
Thank you very much. And as I mentioned, if you folks more about that, we are going to have nurse practitioners as our panelists the week of, it's on April 8th, same time and place. So please just sign up for our webinars and you will get a link to that one. Okay, so I'll come to it. This is a very broad question, and Jennifer in particular, you touched on this, but all three of you have touched on this. But could you describe a little bit more about the governance structure of the primary care networks that you're developing?
Sure, I can start. I think they're quite different across the province. So I'm involved in two primary care networks. And I would say the governance structures are different with both of them. So one of them has become its own nonprofit. And so it has a community board. It has community members. It has subject matter experts like lawyers. I would say it's kind of a working board because, of course, they only have one staff, so it's a very hands-on board. But the benefit of the primary care networks in both of the neighborhoods that we're working is about sort of being model agnostic, bringing as many people together as possible, as many clinicians together as possible that practice in a comprehensive way. So that could include pediatricians, that could include nurse practitioners, that could include midwifery. And so it's a large umbrella. I think sometimes the tension is, does a primary care network need to involve administrative leaders? That I would say is our tension in our current model. And because often in organized team-based care, clinicians get to practice to full scope because administrators spend a lot of time running the organization. And so I think the balance is what's important. I find in Ontario and probably everywhere, we do kind of like the policy pendulum. And so we didn't really coordinate or consider the clinician experience for a very long time. And then now I feel like we're really heavily considering particularly the physician experience and prioritizing physician leadership. And probably the right way is somewhere, in the middle. But yes, in terms of the governance of the primary care networks, I don't think there's consistency. And I think some of them are high performing and some of them are low performing. I happen to be in a very high performing one. And the model is that it is established a nonprofit governance independent organization.
Yeah,
Thank you.
in our case, again, it's relatively new. As I said, we used to have a primary care alliance. It's now primary care network. We've got terms of reference. We have an executive of 8 people, which I think is 2 physicians, 2 nurse practitioners, a pharmacist, a medical secretary, and a couple of others. And we liaise with that group as well as executive directors. And I think that's to Jen's point. We're not quite sure where we in our organizations necessarily fit in. We're not quite sure what the decision-making scope is for the primary care network, nor are they, right? Because they have technically no authority and technically no budget. The Ontario Health team is working with us. It's working with the Primary Care Network. We're trying to just play nice in the sandbox and move things forward. In our case, it's good because we're certainly hearing from some of our colleagues where it's just all physician dominated, which again doesn't bring all the voices that need to be happening. But so far, so good. But it's still early days yet. So.
Yeah, and I'll just say we're just finishing up a paper describing sort of best practices on how we feel primary care networks should evolve over the course of time. And one of the big barriers was I think there was some really loose guidelines, but they just said like go to it, figure it out. And so everyone's trying to do their own thing, figure things out. And we've got some really high performing examples as well as examples from other provinces and around the world. So I feel like, we should have had a little bit more guidance, but we'll get there. But I mean, it's a bit of a wild west right now with the primary care networks.
Well, just while we're on the topic of the structure, I do have a question in here about if there's a role that municipal governments play in supporting the development of these integrated team-based care models.
Well, I guess I can start with that. So in our Ontario Health team, from the get-go, we've actually had municipal partners at the table. Locally, we have been partnering with our two municipalities to advance healthcare issues in the area. So, for example, part of our challenge is when I got here, there were only 4 other physicians in the area. Now there's only 2 other physicians in the area. So our municipalities are getting worried. One of our municipalities actually has been subsidizing those 2 physicians to the order of $300,000, or about 3% of their tax base. And so they're starting to struggle with that because they have a lot of other competing pressures. So we're working with them and funders and others to try to find solutions going forward and again, associated with the neighborhood health home model, right? The neighborhood health home model, in our case, for our spoke, is really us plus these 2 physicians who are supported by that municipality. So we're having conversations with both municipalities. We're having conversations with the physicians. I'm meeting with them again on Monday. So it's, I think the end, we know that the municipalities hear it when they're told. So the municipality also subsidized the lab service. And so they cut that just before December. And then there were thousands of people writing petitions saying, no, we want this on our tax base, right? So you've got people who want it on the tax base and others who don't. And then when you try to shift it back to the provincial responsibility, there's pushback. So it's messy, but we're partners and we'll work it out with them.
Now we're running to the last few minutes. I do want to save a tiny bit of time for a final thought from each of you. So maybe briefly, can somebody speak to the relationship between peer leadership, the funding for this peer leadership and relationship with families when it comes to mental health wraparound services specifically? So you offered a few other examples around what peer leadership can do, but maybe could you speak to the mental health supports a little bit more?
Sure, I can start. Yeah, so I mean, our peers are our community health ambassadors, as we call them, as their employees, and get all kinds of training. So we have done mental health first aid, for example. So when they're out in the community and they experience someone having in distress, whether that be because of substance use or a mental health concern, that there is, a mental health first responder. We've had conversations with our EMS and our hospitals to make sure that the ambassadors have a clear way of supporting people. We do have a non-police emergency response in Toronto, which makes a big difference. So that is a model that our ambassadors use quite a bit. And then one of our sister CHCs, South Riverdale Community Health Center, is our expert in harm reduction. And so they support us across East Toronto region, similar to what Andy said, distributing harm reduction supplies. Our ambassadors can access those through South Riverdale. They can also bring the South Riverdale ambassadors. So I feel like in East Toronto, there's a lot of collisions, and perhaps clients that are smartly connected to a few different ambassadors for different needs, as well as the ambassadors themselves being proactive at uncovering new concerns or new needs. I remember there was that at that time where there was that shortage of infant Tylenol, if everyone can remember that
Mhm.
time. And so our ambassadors were getting hundreds of calls about, like, do we really have to go to the emergency department to get Tylenol for our child with a fever? And so we worked with our ambassadors and actually with our local hospital to get some of their infant Tylenol into a local pharmacy. So their compound pharmacy, and they moved it to our local compound pharmacy. And so our ambassadors could then say, no, don't go and spend 12 hours in that emergency room. Go to X pharmacy, and they will be able to dispense you some infant Tylenol. So things like that, I think, are really important to keep people well in the community.
Thank you. That's great. I'm going to end the questions there, though the folks did have a lot of questions at the end there. So please keep joining our webinar series, and you can ask our next set of panelists some more questions. But what I'll do with the last few minutes we have here is maybe ask if each of you could tell me in a minute or less, a final thought of like what keeps you going in this work. So maybe I'll go Jennifer, then Andy, then Jen.
Sure. I mean, for me, it's health equity and the provision of team-based primary health care. I mean, that's for me the MO for all what the work I do. I see the direct impact of the importance of tailoring service delivery to make sure that care meets the needs of the folks we're serving. And when you do that with a health equity lens, it truly makes a difference. So that's what I'll say. Thanks.
Thank you.
So I'll just leave it with, so one of my directors who just retired is a big Meg Wheatley fan. And so one of the things that the two of us tried to do in the 15 years that we worked together was to create an island of sanity. And so trying to create a psychologically safe place, psychologically safe for our staff, for our clients, and for our communities as best we can, because the world, as we know, is not necessarily the most safe place. We created a Justice, Equity, Diversity, and Inclusion Committee. We raised the first Pride flag. We raised the first Indigenous flag. And people said you can't do that in rural southwestern Ontario. So I think there are great people everywhere. It's about finding your allies, and each of us can make a difference in the small things that we do. And it's amazing how those can ripple out away from us. So.
I love that answer, Andy. Yeah, I think it is being rooted so close to community that you see the impact quickly, right? So I'm so lucky to be in our Thorncliffe Park Community Hub today, walking through young people planning a community iftar, women getting help breastfeeding, people getting connected to a dietitian, people getting, status through their lawyers. So it's like very motivating to be in the mix of things. As a health system leader, I think you're often removed. And so I think community health and primary care is that really special place where you work at a systems level, but you see the impact incredibly quickly because you're so close to the ground. And yeah, so that's really, really motivating. And I appreciate the opportunity to be with two of the very smart colleagues, Jen and Andy, that I get to see virtually quite a bit. And yeah, it does feel like a really strong connection that the Alliance has supported us to make sure that we all have each other's back, which is really exciting.
Thank you so much. I think we have a lot to learn from you folks, and that's exactly why we're running this webinar series, to learn from what's working, what barriers we still have. But I think we've learned a lot today, and this has been quite inspiring, I imagine, for a lot of people in attendance as well. So thank you to all our panelists. Thank you to Marcy for sharing this session and asking some great questions. And a reminder to everyone who's registered today, you'll receive the video recording of this. So please feel free to share this with your networks, and we can start to build similar systems here in BC. Thank you so much for attending, everybody.
Thank you. Take care.
Bye.
Bye.